Good afternoon, everyone, and thank you so much for joining us today. I'm Dr. Kim Newell Green, and I'll be the moderator for today's virtual Grand Rounds, sponsored by California Health and Human Services and the California Medical Association. Today's talk is entitled COVID-19 and Pregnancy, What are the Risks for Mom and Baby? Next slide, please. Here are our speaker disclosures for your information and viewing pleasure. Next slide, please. And this is the order of speakers we're going to have today, our agenda. Next slide, please. And just a reminder that CME is provided for this series. If you'd like to get CME, you'll be sent a survey after the completion of the webinar, and you can attest to your attendance, and we'll need that so that we can send out your certificates. Just to let you know, we will also post this video online this evening at covidroundsca.org. And we do already have slides attached as a handout if you'd like to download those. Next slide, please. It's May, and it's a time of good news and bad news, as often has been the case in the last several months of the COVID-19 pandemic. California's COVID-19 cases and deaths have plummeted after peaking in the new year, and Governor Newsom is anticipating dropping the tier system altogether in just over a month if all goes as expected. Several counties in our state have already reached the metric that President Biden set for the country to meet by the 4th of July, over 70% of adults receiving at least one dose of vaccine. And yet we watch with dismay the struggles in countries like India. India only months ago had been touted as a success story of the pandemic. The wily virus continues to surprise and to devastate communities around the world. In the face of these joys and sorrows, parts of life go on, from the mundane to the profound. Laundry has to get done and food put on the table. And teens and young adults are preparing for graduations. People are falling in love and getting married, and babies continue to be born, even if in slightly lower numbers than in previous years. During this webinar, we are thrilled to hear from two physicians that you see on your screen, both from UCLA, Dr. Rashmi Rao and Dr. Karin Nielsen, as we discuss the risk posed by COVID-19 to both mom and baby during and after pregnancy. Doctors Rao and Nielsen will share the knowledge from the research and the clinical world about the particular threat that COVID-19 infection poses to pregnant people and their newborns. Following that discussion, we will, as usual, hear from Dr. Erica Pan, our state epidemiologist, who will review the status of COVID-19 in California and our nation, the progress we've made in our vaccination efforts, and the evolution of COVID-19 variants that continue to challenge us as we battle this pandemic. As usual, we hope to have time for questions after our presenters, and so please do submit any questions you may have using the question box in the control panel, which is located on the right-hand side of your screen. Now I'd like to turn the time over to Dr. Rashmi Rao. Dr. Rao is Health Sciences Assistant Clinical Professor of Obstetrics and Gynecology at UCLA. Her clinical and research interests intersect and include high-risk pregnancy, prenatal ultrasound, rare diseases of pregnancy, both maternal and fetal, and maternal mental health. Thank you so much for being here with us today, Dr. Rao.
Thank you so much for having me, Dr. Green, and to the California Medical Association. That was a lovely introduction. Thank you again for having me. I'm Dr. Rao. I'm from the Division of Maternal Fetal Medicine. And today, through our lecture, it will be brief, but we will touch on some key points. I'd like to discuss just COVID-19 in terms of a quick background, how it affects pregnancy, specifically maternal and neonatal outcomes. We're going to review some current treatments and how we manage our pregnant patients. And then I'd like to end with a discussion about pregnancy and the vaccine. Next slide, please. So SARS-CoV-2, as we are all now well acquainted with, is a respiratory virus from the family Coronaviridae. There are different genera, so alpha and beta, and this particular one that we're discussing comes from the beta genera. You can continue tapping on until this whole slide is demonstrated. So this specific one down here in the bottom of the chart, SARS-CoV-2, it started at the end of 2019 in the Hubei, China province. Actual reservoir was a bat, and it is well known to us now as a respiratory virus, and it enters the human system through the ACE2 receptor. Next slide, please. So it came to our shores early 2020, and as you can see here, we've had in California a rough summer last year and a rough winter again. And you can see that the hospitalized cases as well as new cases and deaths have mirrored this two kind of surge humps that we've been seeing. Next slide, please. And I put this up for historical context to show that hopefully we don't have this surge again, but this is what happened back in 1918 with the H1N1 virus. Hopefully the difference will be the vaccinations, but as we hear of new variants that are circulating in India, like Dr. Green had just mentioned, I think this is important to recognize that we have to stay vigilant. Next slide. So this I just put up here is from the CDC, and this is just to show that over time, and the graph on the right shows you the time frame from January up until April, where we've seen a change in the variants that have been circulating in the United States. We had variants that were more common to the United States early in the pandemic, and now we're seeing more of the, you can see the B117, which was a variant of concern that came from the UK. And so this is constantly changing, and we need to keep an eye on this. We do have surveillance nationally as well as from state and university centers that are equipped to sequence the strains, but it is not on demand. So we don't do as good of a job in this country as some of the European countries at sequencing variants. Next slide, please. So really what we want to get at is, how does this affect pregnancy? So how does COVID-19 affect pregnancy? The truth is we don't have a clear picture yet of exactly the pathophysiology related to COVID-19 in pregnancy. The data really is limited to case series and meta-analysis, although we are seeing some cohort studies that have looked at comparisons between pregnant and non-pregnant patients, as well as COVID positive versus not COVID negative pregnancies. Much of what we do now, the management and our treatment, was driven out of early data that we got from New York, and that's really the majority of our guidelines. But as you know, and I'm sure Dr. Nielsen's going to talk about this as well, we have still big questions to answer, and scientific gaps remain. Next slide, please. So how does COVID-19 present in pregnancy? Well, it presents very similar to the non-pregnant patient. Here is a study that was published out of a priority registry, which is a longitudinal study looking at pregnant women who had COVID-19 in pregnancy. And what we noticed is that the symptoms are very similar. So cough, sore throat, body aches, and fever. Fever is not present in the majority of the patients who presented at this time. The median time to resolution of these symptoms is approximately 1 month. But it is notable that about a fourth of the patients who had COVID-19 in pregnancy were still reporting some symptoms at about 2 months. Next slide, please. So what we really want to get to is the question of, do pregnant patients have a greater risk of severe illness compared to their non-pregnant cohorts? So in prior respiratory viruses, such as the SARS epidemic and the MERS, as well as with the influenza virus, what we did see is that pregnant women would have a higher risk of severe illness as well as maternal mortality. So wanting to see if that is the same thing that plays out with this epidemic. And what we noticed is, this is from a report from the CDC, from the MMWR, when they looked at over 1 million reproductive aged women who tested positive for SARS. They had pregnancy data on a very small percentage of women, but next slide, please. What they noticed was that after they adjusted for the age of the patients, the comorbidities, as well as race and ethnicity, what they noticed was pregnant women were at an increased risk of ICU admission, mechanical ventilation, and death. And another point that I think is exceedingly important is that there were disparities that were very prevalent as well. Black women represented 14% of the cohort, but they represented a 36% of the deaths overall and 26% of deaths of pregnant women. We see something very similar here in California, except we see it in our Latinx population. So I think this is exceedingly important to keep in mind. Next slide, please. This is a cohort study that was published recently and looked at 1,200 patients who had COVID-19 in pregnancy. And this was a big network here in the United States, and it's funded out of the NICHD. What they noted was that most of the patients had very asymptomatic or mild COVID-19. However, about 4% of patients were critically ill. And this is very similar to what we've seen here at UCLA in that there are adverse perinatal outcomes, but it tends to happen more commonly in those who have severe illness. The types of things that we do see, and that was seen in this study as well, is a higher rate of VTE or venous thromboembolism, a higher rate of cesarean delivery, a higher rate of hypertension, as well as preterm birth. And so again, the conclusion of this, which is similar, very similar to what we see, is that severe critical COVID-19 can increase the risk of perinatal outcomes. Next slide, please. So what are we seeing in the world? I mean, I just mentioned what we see here in the United States. This was a very recent article that was just published in JAMA, looking at maternal and neonatal morbidity and mortality, called the Inter-COVID Multinational Cohort Study. Next slide, please. This was a prospective study looking at 43 institutions with 18 countries that were involved, and they compared pregnant women to gestational age matched patients who had COVID to people who did not have COVID. Next slide, please. So compared to COVID negative pregnant women, those who had COVID in pregnancy had an increased risk of preeclampsia, severe infection, ICU admission, maternal mortality, preterm birth, and medically indicated preterm birth. Next slide, please. They also noted that fever and shortness of breath was associated with increased risk of maternal and neonatal complications. And this is the next data point's a little bit of an outlier, I believe, but they noticed that out of the women who tested positive, 13% of their neonates tested positive. We're seeing much lower rates here in the United States. But what they noted was that cesarean delivery, but not breastfeeding, was associated with a higher rate of neonatal positive. Next slide. This was a study that was recently published in JAMA, and I'm not going to discuss neonatal outcomes too much because I know my colleague will probably be discussing that shortly. But this was a Swedish cohort study that looked at babies that were born to mothers who tested positive for SARS-CoV-2 compared to those who were negative. And they saw, again, a higher rate of preterm birth, 8.8 versus 5.5%. And after matching for maternal characteristics, they noted that mothers who had SARS-CoV-2 was associated with a higher rate of NICU admission, respiratory distress, and hyperbilirubinemia, although no difference in mortality, breastfeeding rates, or length of stay in the NICU. Their neonatal test positive rate was quite low, 0.9%, which is similar to what we see here. Next slide. So CDC birth outcomes, when we look at the data here in the United States, this was published earlier in the year, but when they looked at 3,912 live births, they noted that the preterm birth rate for those with COVID positive pregnancies were 12.9% compared to the US population of 10%. And among 610 infants who had test results, the perinatal infection rate was low, 2.6%. Next slide, please. So I'd like to move on next to how do we treat women who are pregnant and have COVID-19. Next slide. We get our guidance from the American College of Obstetricians and Gynecologists, from the Society for Maternal Fetal Medicine, as well as the CDC. Next slide. I'd like to just say that, when this first started back almost a year ago, the Society for Maternal Fetal Medicine published a letter to the US Department of Health and Human Services, really urging that trials that were conducted really included underrepresented minorities and pregnant women when it came to any clinical research related, whether it was vaccine or treatment development. Unfortunately, pregnant women were not included in any of the major trials, but I will present the data and what we do and how we treat women now. Next slide. So general principles of how we treat pregnant women who have COVID or presumed to have COVID is that we universally screen on labor and delivery, and many institutions, especially those with the resources, have adopted this policy. And this was after data from New York show that the asymptomatic positive rate, which can vary widely depending on location, at the height of their surge was on the order of about 10%. And so we also want to make sure that we really mitigate exposures. So separating patients in a well-ventilated room, preferably a negative pressure room, using masks for everyone, And we usually implement all of our CDC infection prevention protocols and limit visitors and contact with other healthcare workers unless it's very necessary. We work closely with our infectious disease colleagues. Next slide. With regards to testing and management, we collect and we send all relevant specimens, so a panel that includes influenza, RSV, as well as COVID. We screen commonly for other viral or bacterial infections, and fetal heart rate and uterine contraction monitoring is implemented right away unless it's against the wishes of the family. Regards to management, early oxygen therapy is key. We'd like to keep the goal target therapy for oxygen for pregnant patients to be above 95%. We always implement early transfer to higher level of care if necessary, and we consider mechanical ventilation when there's evidence of any advancing respiratory failure. Next slide. Other management considerations in pregnancy, we're generally conservative when it comes to IV fluids unless there's cardiovascular instability present. Although antibiotics are not routinely implemented right away, we do consider empiric antimicrobial therapy if there's any concern for a superimposed bacterial infection. We work closely with our ID colleagues to determine which medications will be relevant to our pregnant patients, and I'll discuss that in detail in just a moment. If there's septic shock, we go ahead with prompt management for the targeted septic shock. And when it comes to steroids, we do implement this in pregnancy, and I'll have a short discussion about whether we use dexamethasone or the other steroids. It's important to notify and consult the maternal fetal medicine services if that's available, as well as your neonatologists, the intensivists, anesthesia, as well as your nursing staffing. Next slide, please. When it comes to specific things in pregnancy, such as delivery and mode of delivery, this is very dependent case by case. And what we've instituted is kind of a group decision based off of what is happening clinically, as well as a discussion with the families. This is going to really determine how far along the patient is, whether the patient's preterm or at term, what maternal condition is, what the stability of the fetus is, whether the family wishes for us to intervene on the sake of the baby, especially depending on how early the pregnancy is. And we like to consider regional anesthesia over general anesthesia, especially to mitigate exposure. We don't have a strict rule regarding the type or the mode of delivery. So cesarean deliveries, really, we try to leave that for obstetrical indications. There is no contraindication to a vaginal delivery with a patient who has COVID-19. We do consider earlier movement towards delivery so that we don't end up in an emergency situation. And again, that's to prevent kind of the unstable management of anesthetic options. Again, we'd like to have regional anesthesia instead of general anesthesia to avoid intubation and exposure. Next slide, please. So in discussing which particular therapies we use for COVID-19 in pregnancy, on your left side, other than remdesivir, really we don't use any of these other medications, or we haven't used any of these medications in pregnancy. There really haven't been significant benefits to these interventions, especially when you look at the meta-analyses, although for remdesivir, for severe patients, there has been some studies that show that there could be a survival benefit. When it comes to IL-6 inhibitors or convalescent plasma, we have used this in pregnancy. There is no data specific for pregnancy, but we believe there could perhaps be benefits to these treatment options. They have been used, again, without any adverse events, but again, no trials or data specifically looking at pregnancy. Next slide. So regarding steroids, steroids actually do show a survival benefit, and this came out of the recovery trial in the UK, which showed that 6 milligrams of dexamethasone for 10 days showed a survival benefit, especially for those who had been ventilated. There are other studies that have looked at other steroids, such as hydrocortisone and methylprednisone, and we briefly did discuss that in our obstetric units, given that dexamethasone does cross the placenta and can have fetal effects, whereas hydrocortisone and methylprednisone are non-fluorinated corticosteroids. However, despite that, and despite there being some data, it really hasn't been shown in the larger trials to have as much of a survival benefit as did dexamethasone. Next slide, please. And here is a meta-analysis that looked at all the studies that did look at whether it's dexamethasone, hydrocortisone, or methylprednisone. And you can see that the recovery trial with dexamethasone shows the largest benefit. and therefore we really do stick with dexamethasone even in pregnancy. Next slide, please. So monoclonal antibodies, now these are for patients who are non-hospitalized, so non-severe patients who are not hospitalized. There are data both in the New England Journal of Medicine, whether it's from the BLAZE trial or from Weinrich, and this is the singular monoclonal antibody bamlanivimab versus the Regeneron cocktail. And it did show that there was a reduction in ED visits as well as hospitalizations. And therefore we have, next slide please. We have given this to our patients at UCLA. Our overall N is quite low, but we have included pregnancy as a risk factor, given that there has been association of severe disease or severe infection with pregnancy. It's a single infusion, whether it's the singular or the cocktail, and it's given over 60 minutes. And if any of the patients have the risk factors listed below, including pregnancy, we do discuss that this is not standard of care, but this is an EUA approved medication. Next slide, please. So I'd like to end on just COVID vaccination and pregnancy because this is a very hot topic. So here are the vaccines that have been approved in the United States. You got the Pfizer, the Moderna, both mRNA technology, and the J&J or the Janssen vaccine, which is an adenovector. So according to Society for Maternal Fetal Medicine and how we counsel our patients, we say that whether they're pregnant, lactating, or postpartum, they are eligible to receive any of the FDA authorized COVID-19 vaccines, so any of the ones that are listed here. However, given the recent data that came out based off of the J&J vaccine for the risk of thrombosis and the thrombocytopenia syndrome, we do mention that they should be aware of that risk and that other FDA authorized vaccines are available to them. Next slide. So, there's a lot of controversies when it comes to COVID-19 vaccines, and I'd like to just discuss where some of that comes from and the data associated with it. There's some sequence overlap between part of the SARS-CoV spike protein and a placental protein, and this, I believe, led to many rumors that the mRNA vaccine can affect fertility. There is no data that would support this at this time, and both ASRM, and ACOG both came out with statements reflecting that. Next statement. Next slide. So what other data do we have? So pregnant women were not included in any of the initial phase 2 and phase 3 studies, whether it was the mRNA or the J&J adenovector. However, 26 people did become pregnant while they received the vaccines in the trials, 12 in Pfizer, 6 in Moderna, and 8 in Janssen, and there were no adverse or early concerning signals based off of those patients. Similarly, we have DART data from the animal models, which also shows that there have been no safety-specific signals based off of the preliminary reports for each the Pfizer, Moderna, and the J&J vaccines. And we don't think there's any biologic reason why this would cross the placenta, and we have not seen any evidence of that in the breast milk either. Next slide. What data do we have from the MMWR, from the vaccine safety monitoring from the CDC? This was published back in February, just a couple of months ago. They had data based off of, at that time, 10,000 women who had been pregnant. Most of the adverse events that were reported were not significant. To date, there are over 80,000 women who have registered to VAERS or the V-Safe on the CDC, and they are continuously following those patients, and we are hoping to get that data. But as of now, we have not heard any safety signals from vaccination. Next slide. The good news is Pfizer is now including pregnant women. There's a phase 2/3 clinical trial that just started in February where they have already dosed the first participants. They're including pregnant women who are between gestational ages 24 and 34 weeks, planning to follow them for 7 to 10 months, as well as the infants for 6 months. So my hope is that within the next year, there will be some data and we can officially recommend the vaccination to our patients. Next slide. But despite that, all of our governing bodies, the ACOG, CDC, ASRM, recommend that vaccines should not be withheld from pregnant individuals who meet criteria based off of the ACIP recommended priority groups. We also think that COVID-19 vaccines should be offered to lactating individuals similar to non-lactating individuals, given the lack of any data for any concerning signals. And we always mention that COVID-19 vaccination can cause fever in some patients, which has been reported up to 15–16%, especially after the second dose. However, there is a very low absolute risk of birth defects. Next slide. So in conclusion, we are continuing to have high vigilance and continue our infection prevention protocols and keeping a high index of suspicion, given that COVID-19 can be a serious issue, especially in pregnancy. I tell all my pregnant patients, there's one thing I know for sure, that you can get COVID-19, and if you do get severe maternal infection, it is a cause for concern. There is data that severe maternal infection is linked to adverse obstetric and neonatal outcomes. And I think for all of us, in terms of management and treatment moving forward, the inclusion of pregnant women in clinical trials and the availability of treatment and vaccines is vitally important for counseling and knowing appropriate management strategies. And lastly, I'm going to end with our recommendation at this time, which is to not withhold vaccination from pregnant or lactating women. Next slide. So that is the end of my talk. I'd like to thank everyone again for having me, and I'll be available for questions.
Thank you so much, Dr. Rao. We actually have a lot of great questions coming in. We're going to hold off on those until after we hear from Dr. Nielsen. So let me introduce our second speaker. Dr. Karin Nielsen is a professor of pediatrics in the Division of Infectious Diseases at UCLA Children's Hospital. She's an attending physician for pediatric ID at Mattel Children's Hospital and the co-director of the Care for Families HIV clinic at UCLA. Dr. Nielsen's main area of research has been perinatal and pediatric infections, particularly focused on the prevention of mother-to-child transmission of HIV and prevention of HIV sexual transmission, as well as treatment of this disease. She's actually worked extensively in collaborative clinical studies in the US and also in many places in the world, including Brazil, Sub-Saharan Africa, Europe, and Asia, and has touched many other infectious diseases in fields including Zika virus perinatal infection, other congenital infections, arboviral diseases, and TB in children. During the COVID-19 era, she has switched into that, as many of our clinicians have, and in collaboration with a multidisciplinary team from UCLA and Fiocruz in Brazil, I do not speak Portuguese, Dr. Nielsen developed a study of maternal-infant outcomes from COVID in pregnancy called the COMP study. It's enrolling participants both in LA and in Rio de Janeiro. She's also an investigator in the COVID Pregnancy Registry, which is based in Europe and is presently conducting epidemiologic studies of COVID-19 infected youth in Los Angeles and in Rio de Janeiro. So with that, you sound busy and I'm exhausted already, but please take it away.
Hi, thanks Dr. Green for the invitation, and also thank you to the California Medical Association and my dear colleague Dr. Rao for inviting me to talk to you today. So I'll be talking about COVID-19 in mother-infant pairs, focused primarily on the neonate today. Next slide, please. So we've gone over the educational objectives. Next slide, please. So as Dr. Rao alluded to in her excellent talk, pregnant women are really at increased risk of infection throughout pregnancy. There's this immunologic paradox of pregnancy where there is a relative immune suppressive state during pregnancy, particularly in the third trimester of pregnancy, which for the woman not to reject the fetus, she lives in this relative immune deficient state. This, of course, has benefits for maternal fetal outcomes, but there are also associated risks with increased likelihood of acquisition of infection. Of course, we know about the physiologic changes in pregnancy as well that predispose women to gestational diabetes or arterial hypertension, and these can also complicate any infectious process that's ongoing. And then, of course, there are gender dynamics that can impact transmission with, interestingly, pregnant women are more likely to suffer violence from their partners and also sexual abuse, which can facilitate transmission of a multitude of infections as well. Next slide, please. So Dr. Rao already went over this, but just briefly, when we talk about other beta coronaviruses, from the epidemic in China and also Canada in 2003 of SARS coronavirus 1, that virus carried a very high maternal mortality rate of 25%. And the Middle Eastern respiratory syndrome virus, which is another coronavirus, even though very few pregnant women were enrolled, there were 10, I believe, that were seen in that during that epidemic. 3 out of 10 infants born to these women died shortly after birth or were stillbirth. So that carries a 30% infant mortality rate. The rate of miscarriage in both of these infections was over 50%, and over 80% of the infants born to women during these prior epidemics were preterm, which was astoundingly high. Next slide, please. So, I mean, it goes without saying the tremendous damage that COVID-19 has, triggered across the world. This is data from the Johns Hopkins website dashboard, which you're probably all familiar with. Over close to 160 million cases reported as of last night, with over 3 million deaths, which is probably an underestimate given that testing has been limited in a number of countries. But the United States has led this sad statistic with 33 million cases reported to date, followed by India and Brazil. And the number of deaths in the US overall is approaching 600,000, followed by Brazil and India, which is a gloom statistic. Next slide, please. So close to 4% of the population infected with SARS coronavirus 2 has died. We know that the virus is very contagious, transmitted via respiratory droplets. It can be airborne in some rare circumstances. And with the Wuhan strain, the original strain, one person can infect on average 2 to 2.5 individuals at a time. With the new variants, particularly the one from Brazil and the one from South Africa, it's a much more transmissible virus. So we are seeing more morbidity and mortality, not because the virus is necessarily more virulent, but just because of its higher infectivity rate. And of course, as Dr. Rao explained, reproduction number of the viruses can be decreased by our mitigation measures, including the masking, social gatherings, stay at home, and universal symptom screening. Of course, pregnant women and their babies are two populations that are increased risk of serious complications because of the pregnancy physiologic changes we already mentioned, and also because neonates have immature immune systems and are not very good at fighting infection. Next slide, please. So as Dr. Rao has mentioned, pregnant women originally were thought to maybe be at increased risk, but maybe they were not. This was early on in the epidemic, and it was kind of questionable whether they would be at risk or not. Maybe they would carry the same risk as other people in the general population. Next slide. However, we found that that's not the case. COVID-19 does exacerbate some comorbidities and has been clearly linked to preterm birth. And however, COVID-19 infection, as Dr. Rao explained, is not an indication for delivery. Next slide. Given that there was a recent surge in Brazil in January and now in March in Manaus and then in Rio and Sao Paulo, and the number of women infected during pregnancy was extraordinarily high, especially with a lot of maternal mortality and morbidity. This prompted like an editorial at one of the main newspapers in Brazil last month, just mentioning how many pregnant women were on assisted ventilation and ECMO and how they were fighting for a victory of life over death. Next slide, please. And I have worked a lot in Brazil, and this is a paper that came out last year, I believe in May 2020, or at least it was accepted in May 2020, published in July. And it was just showing that the tragedy of COVID-19 in Brazil with so many maternal, over 124 maternal deaths at that time and still counting. And the mortality rate reported to the DataSUS, which is a Brazilian database for the unified health system, was about 13%. And in the first 2 months of the epidemic in Brazil, the maternal mortality rate was already amounting to 10%, it was equivalent to 10% of the annual maternal death rate for the whole country, and this was published as an editorial in The Lancet in May 2020. Next slide, please. So it was clearly shown that COVID-19 can pose significant risk to pregnant women who are at risk for severe illness. Next slide, please. And as Dr. Rao alluded to, pregnant women unfortunately were not able to participate in the major vaccine trials, nor were they able to participate in remdesivir clinical trials or trials of monoclonal antibodies. Next slide, please. But fortunately, by April 2021, even though all the obstetrical societies had already recommended vaccination of pregnant women, the CDC did openly recommend that pregnant women should get the coronavirus vaccine. But this is a recent phenomenon. I'd like to say that in Europe, it's still not officially recommended in all places to immunize pregnant women. And in Brazil, pregnant women are not routinely being immunized. There's a movement towards including them in the women who in the populations at risk. So we are seeing still a lot of dreadful consequences to this population. Next slide. So I'm not going to go over this except to say that there is transfer of, there have been studies showing that there's transfer of maternal antibodies that were triggered by the vaccines to the babies. Of course, the duration of that immunity in the babies is unknown, and whether these antibodies will persist and how long that remains to be seen. We have seen in our studies, and others have published in their studies, that there's definitely transfer of maternal IgG after SARS coronavirus to infection from the mother to the baby, which could potentially protect this baby for the first 6 months at least of life, especially in women who've had more severe illness and form antibodies. Next slide, please. So one issue is vertical transmission, and there have been throughout the pandemic several reports of newborns who were found to be positive right after birth, but it was unclear if they were really infected before being born or actually after birth by nosocomial transmission. Infants who contract the virus, they tend to do actually quite well, and it's very rare for them to develop pneumonia. However, it's interesting that they do tend to shed the virus for a number of weeks, especially with stool shedding of the virus. This was reported even early on in the pandemic from out of China and has been confirmed in other reports. The virus has been seen in the placenta of women who had miscarriages because of complications of COVID-19. These placentas might have clots as well. Although the virus has been detected in human breast milk, it is not transmissible through breastfeeding. At least no study has shown that yet. Next slide, please. And so the data is variable wherever you look in terms of how frequent does in utero transmission of coronavirus to occur. So there was a study that looked at 66 placentas in women who had COVID, and the SARS coronavirus 2 was not present in any of those. But as you look through multiple reports in the literature, transmission rates have varied from 0 to 4.3% or even higher, as Dr. Rao alluded to in a study from Europe, to 13%. But it is thought that this is very, very low. One interesting caveat I'd like to explain is that with respiratory virus, it's unusual for women to transmit infection in utero. They would have to be viremic, and the virus has to cross the blood across the placenta to reach the baby. And potentially women who are viremic, severely ill, and have a lot of virus circulating in the blood would be at risk for transferring the virus to their babies. But this seems to be fortunately rare. Next slide, please. So vertical transmission is unlikely, although the virus has been seen in amniotic fluid and placental samples, and there have been positive nasopharyngeal swabs from babies at birth, but that seems to be very, very rare. And transmission during delivery also seems unlikely. We've actually looked at vaginal swabs in one of our studies looking for positive PCRs, and the virus has not really been identified in cervical vaginal secretions. Next slide, please. Of course, postnatal transmission can happen via respiratory droplets, and today we believe that most newborns who are infected with the virus are infected by close contact with their mother and not really by vertical transmission. Next slide. So that leads us to the next question: how often does transmission through breast milk occur? There have been individual cases in China and Germany that thought that maybe transmission had been through the breast milk, but of course, these mothers were not wearing a mask during the time that they were collecting the breast milk, and the samples may have been contaminated. Next slide, please. So the risk is very low, and breastfeeding should never be contraindicated for women who have SARS coronavirus 2 infection, and neonates will benefit from breastfeeding from their mothers. Next slide. And of course, we know that breast milk is important for nutrition and also for immunologic development. Next, please. So the guidelines have shifted over time, and they have transitioned to maybe not breastfeed to now encourage breastfeeding of women who have had COVID. And there's really no evidence to suggest that it poses an increased risk when babies are nursed. And interestingly, replication competent virus has not really been conclusively shown to be present in breast milk. As you can see here, the feeding method has changed over time, reflecting changing guidelines in terms of women breastfeeding their infants. Next, please. So breastfeeding is safe, of course, but preventative measures should be followed. Of course, it goes without saying that women should wear masks, they should wash their hands and breasts, and should use a well-ventilated room during feeding if they have active SARS coronavirus 2 infection. Next. And they should breastfeed, but when they express breast milk, they should be very careful using proper hygiene. And also, breast milk can be fed to the neonate also by someone who is uninfected. Usually we have seen parents, fathers do that in a lot of our population. We have seen also that women who are breastfeeding for the first time, it's their first infant because of the COVID situation and sometimes counseling not being available. I have actually seen that a lot of the women who are following their babies have had difficulty breastfeeding, not necessarily because of COVID, but because of the pandemic situation. Next slide. Should mothers and babies be separated if a woman is COVID-19 or SARS coronavirus 2 positive at the time of delivery? That is also a guidance that has shifted over time. Originally, it was thought that they should be separated, like in situations of TB, for example. But now we do encourage mothers and babies to room together, as long as the mother is healthy enough to provide self-care and there are appropriate preventative precautions so less transmission occurs. So the number of women separated from their babies has decreased dramatically. As you can see, this reflects September 2020 last year, and the rooming together has increased. Next slide, please. So something that has also changed is the perception of infant outcomes over time. This is a paper, one of the first papers published out of China, Wuhan actually, which looked at pregnancy outcomes and infant outcomes in the first 7 babies who were born to women who had COVID during pregnancy, and all babies were discharged, all babies were term, and actually that paper mentioned there seems to be no risk factor for mothers and for their babies with SARS coronavirus 2 infection. Next slide. However, that has not been the case, and this has been disproven in multiple other studies, large studies. This is a slide from the COVID Pregnancy Registry, which is a registry of maternal and infant outcomes. It's based out of Switzerland. David Bode is the PI, but it includes multiple sites across Europe, United States, and also South America. And just to reinforce what has been said before, the risk of preterm deliveries, you look at infants born at less than 37 weeks, in babies of mothers who had severe maternal outcomes, roughly two-thirds of that population actually were born at less than 37 weeks of age, and 52% of these babies were actually even born at less than 34 weeks, underscoring the problem of prematurity and babies who are born to women who have severe disease. Next slide, please. And this has been shown by Dr. Rao, but I just want to emphasize here the risk ratio of 1.6 for preterm birth in the inter-COVID multinational cohort study, which is also a similar international registry. And the risk of perinatal mortality or morbidity was 2.14 in this study as well. Next slide, please. And Dr. Rao also mentioned this study that was published 2 weeks ago in JAMA, a study out of Sweden, out of 90,000 women followed over time. And I just want to emphasize here the odds ratio of what was associated with maternal positivity, admission of the babies to the NICU, and the odds ratio was 1.5. Respiratory distress in the babies, not necessarily associated with prematurity. Odds ratio, if mom had COVID at the time of delivery, 2.4. Any respiratory disorder in the baby, an odds ratio of 1.4. And of the baby being jaundice, an odds ratio of 1.5. Infant mortality, fortunately, was not different between the two groups. However, 21 infants, 1%, as Dr. Rao showed, were positive for the virus, and which is similar to the statistics described elsewhere. Next slide. So most babies will have favorable outcomes even if they do become infected. 1 or 2 to 5% of babies have tested positive. And the complications that we have alluded to are respiratory distress, low birth weight, in addition to prematurity. However, babies are vulnerable and they can have atypical manifestations of SARS coronavirus too. They can be manifest as poor feeding, as diarrhea, or other GI symptoms. Children have very frequently GI symptoms following COVID-19 infection, or they can have a presentation such as late onset sepsis with fever and leukopenia, and that has been described in some babies, this is fortunately rare. Next slide, please. Children in general are largely asymptomatic, or they have mild symptoms. GI symptoms are highly prevalent. Of course, we have the complicating factor of pediatric multisystem inflammatory syndrome in older children who are infected. Certainly that has not been shown in neonates, but that's a severe condition with vasculitis and with inflammation in two or more organ systems. But generally in children, the symptoms dissipate quickly within 2 weeks. But fecal viral shedding has been shown to be frequent. Nevertheless, if you have newborns or young children who have an underlying condition, they can and are at risk of developing severe complications, and they're more likely to be admitted to critical care. And we've seen a number of those cases at UCLA. Next slide, please. In a study that we conducted at Fiocruz in Rio, this is a large slum area, and the castle in the back is the Fiocruz, Oswaldo Cruz Foundation Library. There's a huge community there, and we were studying transmission from between children and transmission to adults, and we enrolled 370 children less than 14 years of age. But I put this slide in just to highlight that children under 1 year of age, they're more likely to be symptomatic. Actually, in our study, they were more likely to be symptomatic than any of the other age cohorts enrolled in our study, which was of interest. And this actually mirrors what the CDC has reported in their analyses of children and how frequently children have symptoms. It's the ones under 1 year of age who more frequently manifest with symptoms. Next slide, please. So I just want to talk about pediatric long-term outcomes here, which is a focus of our studies at UCLA of the COMP study. Next slide, please. So maternal immune activation during pregnancy really has implications to the fetus. There's a lot of epi data and also animal data that implicates maternal immune activation during pregnancy with subsequent development of central nervous system disorders. And these can be autism, schizophrenia, and also cerebral palsy. Of course, maternal immune activation can affect fetal brain development and lead to changes in brain structure and function, and can lead to neuronal dysfunction and also different behavioral phenotypes. why does this happen? The mechanisms behind this seem to be maternal and fetal immune dysregulation through expression of cytokines and chemokines that should normally not be induced or repressed. And there's also this two-hit hypothesis where an infant, a fetus that is developing in an environment of maternal immune activation may become more susceptible to infection. And of course, this might depend on when is infection happening, whether it's early versus late in pregnancy. There have been even studies in autism that show that prolonged maternal fetal fever during pregnancy may lead to a higher chance of children having autism in the future. Next slide. So during the Zika virus epidemic, there was significant public attention to the detrimental effects of maternal infection. Of course, the risk of microcephaly, which was really just the tip of the iceberg during the Zika epidemic. We have to differentiate, however, that viruses such as Zika, cytomegalovirus, or rubella virus are clearly teratogenic viruses that cross the blood-brain barrier, that are neurotropic and will cause direct teratogenicity. And this is different from what we're seeing here with COVID. The virus is not teratogenic per se, but it is inducing this syndrome of maternal immune activation. And following historic outbreaks of flu, of measles, or mumps, or rubella, or even polio, there have been increases in neuropsychiatric illnesses. Following a 1964 rubella pandemic, the incidence of autism spectrum disorder and schizophrenia in subsequent years rose from 1% to 13% and 20%. Interestingly, children with congenital rubella, for example, have a higher risk of autism of about 5%. And that has been shown in other infections as well. We also saw that with Zika. So even though the majority of pregnancies will lead to healthy offsprings, it is a problem of follow-up as well, because if there's resulting CNS disorders that would happen many, many years later, we might not pick these up. And of course, autism, the diagnosis is usually made starting at 2 years of age, and diagnosis of schizophrenia will happen in the mid to the late 20s. So that would be very hard to correlate with maternal insult during pregnancy. Next slide, please. Our work on Zika kind of highlighted the need to have long-term follow-up of children who even looked normal at birth. They might have subsequent delays in neurodevelopment between the ages of 2 to 5. And we actually noted that Zika was a very transmissible virus, and the cohorts that we looked, 2/3 of the children, 65%, had evidence of transmission, even if they did not have any features of congenital Zika syndrome or any neurodevelopmental delay. So it seemed to be a highly transmissible virus, which is very different from SARS coronavirus 2. Next slide, please. So based on the work that we had been doing before looking at Zika, we developed the COVID outcomes mother-infant pair study. Dr. Rao and I are investigators on this study, and we've been looking at viral shedding, clinical features, but also on immune profiling of COVID-19 positive pregnancies in collaboration with colleagues in the Cleveland Clinic. And I'm just going to show very briefly data on the first 35 mother-infant pairs enrolled in the study. We've actually in our study have now more than 300 mother-infant pairs, counting more than 140 at UCLA and over 150 in Brazil. Next slide, please. So through next generation sequencing, we looked at more than 100,400 cytokines and chemokines, and we saw that a number of cytokines were significantly altered in COVID-19 exposed babies. And this was much more prominent in infants born to mothers who had severe critical disease, which is the red panel on the right. Next slide, please. And this is a volcano plot that's actually showing the immune profiles of babies who were born to severe critical COVID-19 infection at birth. And you can see that they have very distinct chemokine, cytokine expression that are different from healthy control babies, and also babies born to mothers who had asymptomatic illness or mothers who had mild, moderate disease. And the cascades that were implicated in these babies born to mothers with severe disease were the immune signatures were those that are involved in development of the respiratory system and also development, neurodevelopment. We have now expanded this analysis, and we are hopefully submitting a review of a manuscript on the topic where we looked at cytokines in 92 infected mothers and 45 of their babies, and the results still continue to hold. This is not because the babies tend to be more premature, because even in babies who are born at term to severely ill mothers, they have very distinct cytokine chemokine profiles. Next slide, please. What is important is that we are seeing definitely that it's the COVID-19 disease in the mother that is associated with adverse neonatal outcomes. As the mother becomes ill, these cytokines, chemokines, and this immune activation tends to repercuss in their babies, not only because they can be born prematurely, but also because there is stimulation of inflammatory cytokines. Interesting, something I learned in the last year is that actually chemokines, cytokines do not cross the placenta. The chemokines and cytokines that the babies exhibit at birth, which are altered, are very distinct and very different from that of their mothers at the same time point. And interestingly, the cytokines in the cord blood are different from that of the babies and are different from that of the mothers. So this is an area that clearly needs to be investigated much further. And we definitely need long-term clinical infant follow-up of these babies to determine, if there are any clear associations with neurodevelopment and maternal illness and inflammation during pregnancy. There is a cytokine storm in a lot of these patients, and there's a lot of immune dysregulation. So this remains to be seen if we are going to be seeing repercussions in the future. Next slide. So I just want to acknowledge our team who's been instrumental in working with us. Dr. Rao, I was just working on the manuscript this morning, and I was just thinking that we would have never been able to do any of this study without our OB colleagues who have been recruiting all our patients and enrolling them. And I want to also thank Dr. Fajardo, who's a neonatologist who has been instrumental in following these babies in the NICU, and Dr. Katie Cambu, who is an adult infectious disease fellow who's been really diligent about following these babies and helping with the COMP study. Dr. Jay Jung in the Cleveland Clinic and Jolyn Sinfu have been responsible for all the immune profiling data and have been very generous with their time and finance, given that none of these studies have actually been supported by any grants until now. We just got 2 grants last week, so we're very happy about that. But until now, all of this was done without any support. We are enrolling babies as well at Fiocruz. Dr. Patricia Brazil, who's a long-term collaborator, works with us on this, and we have a group in Germany and Austria that helps us with neurodevelopment. Thank you very much.
Thank you so much, Dr. Nielsen. I definitely knew nothing before this about maternal immune activation and how that might impact babies. And as a pediatrician, it's really important for all of us to know that infants who have been exposed to any infection really in utero may have long-term side effects. So thank you for that insight. Dr. Rao, do you want to join us for a couple minutes of questions before we transition over to Dr. Pan? There was a lot of interest, as you can imagine, about vaccine safety among pregnant women. And I think that point was made really clear, but I just want to ask I'm a patient in the room, and I just want to ask you, Dr. Rao and Dr. Nielsen, if you have any advice as well, some specific questions. So I am planning to get pregnant, not really, but I'm your patient. Should I wait to attempt to get pregnant until I'm considered fully vaccinated? What do you think, Dr. Rao?
Well, I definitely recommend getting vaccinated as soon as possible, just because the risk of getting COVID is a lot higher than any theoretical concern for the vaccine. So while whether it was during the actual pandemic or the surges of COVID, I don't think anyone necessarily needs to wait to get pregnant. But I do encourage getting the vaccine as soon as possible. So I think they're mutually not exclusive, but there's no medical reason to wait on that.
Right. Here's another specific question. I had COVID during my first trimester during 8 weeks of pregnancy. I'm now 24 weeks, and I'm not sure if I should get vaccinated. What do you think?
So that's a good question. You know, we are seeing that antibodies persist while you've had COVID in the past. However, we don't know how long they persist. We do know antibodies are crossing over from mom to baby, so having antibodies in general, we do think will be a benefit to the baby. But at some point, I do think that the antibodies will wane. And so I do think, again, back to my recommendation that vaccination is definitely a good thing. And if that is a possibility to do in the pregnancy, then I would do it.
Great.
I'd like to add to this question if I can.
Please.
You know, women who have, people in general who have very mild illness might not form antibodies. And in some of the surges, we've seen people become reinfected again. So even though they might develop T-cell immunity, they might not have a humoral immune response, and they are at higher risk of reinfection, especially with other variants. So definitely, that is another reason why people should be immunized.
Great. So a resounding yes, I think. And Dr. Rao, one final question. I know you have some clinical work to do. Do you recommend closer monitoring, it sounds like so, of pregnant women who have COVID? And should that be done in conjunction with an MFM doctor, even pre-delivery?
So, you know, there haven't been long-term kind of adverse outcomes that have been linked to just getting COVID if it hasn't been super severe. So we don't have hard data on that. But for all of our patients who have had COVID in pregnancy, we at least monitor for fetal growth because we don't know yet if there have been links to fetal growth restriction or preterm birth. It does not necessarily have to be monitored by a maternal fetal medicine physician. However, if that is something that's available to our general practitioners, I think at least checking in one time in the third trimester, making sure that we obtain a fetal growth evaluation, and then routinely just making sure that there are no signs of preterm birth. Those would be kind of the things we recommend at this time.
Great, thank you. And one final question for you, Dr. Nielsen, before we bring on Dr. Pan. Given that we do know that there are potential consequences from this cytokine storm within women, or just within mothers who have some kind of immune activation, what type of follow-up and monitoring would you recommend pediatricians do of infants who were born to COVID-infected mothers, and maybe extend that to other infectious diseases like Zika, obviously you talked about that?
I think neurodevelopmental follow-up is very important, and we have been actually monitoring these babies very closely in terms of we are evaluating them at 6 months. This is part of a study, but I think especially babies who are born to women who had severe illness during pregnancy, they should be followed, and they should be carefully watched to see if they're meeting their milestones. And certainly this should go beyond 12 months because, for instance, if there is any risk of ASD, autism spectrum disorder, they should be followed until age 2 or 3, just to make sure that if anything happens, they can be followed very closely. So I think it's the neurodevelopmental part that needs focus, and also potentially, you know, some of the pathways being identified are related to respiratory function as well. So it should be, their respiratory function should be surveyed as well, especially if babies have reactive airway disease very early in life. So that probably warrants attention as well.
Great, thank you so much. And thank you to both of you. We are going to now welcome on Dr. Erica Pan. Erica Pan is an old friend of ours in the speaker series, and she is the California State Epidemiologist and a Deputy Director at the California Department of Public Health in the Center for Infectious Diseases. Thank you so much, and welcome back, Erica.
Great, thank you so much for having me. Good afternoon, everyone. And one last plug just for one of those questions, I would also just echo that my understanding of data around prior infection versus vaccination is there's a much stronger antibody response after vaccination compared to prior infection. So just yet another reason to encourage everybody to get vaccinated as soon as they can. So with that, I'll launch in to give kind of an overview. Next slide, please. So I'm gonna, I think as I often do, just kind of talk about where we are as a state with our epidemiology, can give you some updates on variants in California. I'm not sure if I've shared before, but always helpful to see where we are with seroprevalence and antibody levels across the state, and our great progress on vaccinations, and some other overall vaccine updates. Next slide. So this is just from our kind of dashboard on our CDPH site, just to kind of show you where we are. I think we are at our lowest case rate we've ever had, I believe, since at least since a year ago, 3.6 cases per 100,000 per day. Our death rate definitely, thankfully, has continued to decrease. And I think in looking at this and other parameters, we've seen that when we were kind of projecting out and thinking where we wanted to get to as a state, I think one thing we're trying to compare to is a bad flu season. And I do think we're at the level of deaths now, which is comparable to a bad flu season, which is also very encouraging. That those numbers continue to improve. As far as test positivity, also a record low for us at 1% test positivity. The testing volume has decreased, which often sometimes the concern then is with testing volume decreasing that you would then see a high proportion of test positive, but that is not borne out. So, and we're continuing to think about how to make sure we're continuing to do testing in high risk settings and certainly in unvaccinated populations to make sure we're working on early detection of cases. And then we'll talk more about vaccine progress in a later slide. Next slide. This is kind of an overview of sort of the course of the pandemic in the state. So that first bump that seemed really big last summer, last July, is our July surge, and then this much, much larger surge we had in the winter. The other orange lines, there's a mix of kind of different interventions we had as far as public health interventions, regional stay-at-home, and then these most recent last three lines are looking at the first X is 10%, second two X's is 20%, and then 30% of our population being fully vaccinated. And you can see as that has happened, we have really seen nice and flat case numbers. Next slide. And yet another way to look at that, but also combined with the blue line here is our cases, 7-day average of new cases. And then the orange line, or I'll go from top to bottom, the red line is actually deaths superimposed. You can see again the curve of that and how that's really dramatically decreased over time. Same with hospitalized COVID numbers. And then the black line at the bottom is the intensive care unit or ICU COVID positives over time. So again, you can see the overall trends and that the hospitalizations and deaths lag a little bit after cases, but that we're seeing great and encouraging trends here in California. Next slide. And then just like to be proud that we have the lowest case rate in the nation right now as well. And I think the lowest test positivity as well. So you can see, and it is, what we're watching very closely along with earlier having seen some surges in other states on the other side of the country, that Washington and Oregon are also seeing some surges. Some people are postulating that, they did not have as high of a peak as far as their case rates during they did have a winter surge, but maybe not quite as high as we saw here in California. So some of that natural immunity we were just talking about, maybe less. Those are some of the theories behind why some of the states are having more surges now than others. Next slide. And then really encouraging data here in California, and you can see kind of broken down by region as well, what we are seeing as far as seroprevalence. So this is data looking at a combination of any reportable antibody that is, all that is mandated reportable, as you all know, to health departments and then in our statewide system, as well as blood bank data that we have from 3 different major blood banks across the state. So, and then we often do what we call a weighted seroprevalence as well, and it usually does not vary too much from the numbers you're seeing here. So we have actually statewide a 67% seroprevalence. And you can see the confidence interval is relatively wide, but encouraging again that we're over 60% or 67% statewide. You can see this varies across the state with some highest at the southern border of 76%, and our lowest probably is in our rural northern areas at around 49%. This does not distinguish between antibody from prior infection versus vaccine. There are some differences, nucleocapsid antibodies versus spike protein antibodies that you can look at clinically. This data does not parse that out. So this is probably a combination of prior immunity and vaccination, but again, really encouraging since, as you all know as well, some people look at, there's been a lot of discussion in the media lately about herd immunity and can we reach it or not, and what is that number? Wanting to hit 70% is one benchmark that people have talked about. If you look at an R0 of 2, your actual herd immunity could be at 60%. So we actually are, again, seeing really encouraging numbers here. That being said, we still want more people to get vaccinated to make sure that we can really minimize any pockets of unvaccinated people and any other ways that variants or other can get into our state as far as thinking about transmission and mutations and causing new variants. Next slide. And then this actually looks at, with an eye to equity. We really have been trying to look at that with every different facet of the data that we look at the state. And so this is seroprevalence looking at the Healthy Places Index quartiles. So you can see, and this is not too surprising, but since we did see the highest disease burden in our lowest quartiles, we saw in general about 40% of our disease in the Healthy Places Index lowest quartile, 30% in the second lowest, 20% and 10%. So here is how you can see the antibody levels or seroprevalence updates over time. And so our highest prevalence as of May 1st is more than 50% of people living in the least healthy community conditions do have detectable antibodies. And you can see that gap is narrowing a little bit as well, probably with a combination again of prior infection and vaccination. Unfortunately, that pattern has been consistent throughout, though, as far as the disease burden in our lowest quartile. Next slide. And then variants, of course, everyone is understandably very interested in what's happening with variants in California. Not on this slide, but just to tell you, I think in March we were able to sequence over 13% of all the isolates in the state, and then I think we're in catch-up mode. There's definitely a time delay between the time we get the data on specimens that are sequenced, but in April we have sequenced, I believe, about 7% of isolates, and actively sequencing isolates in May as well. Lots of efforts going on both at our lab and other local public health labs, as well as other research labs on more timely laboratory data related to variants. And then this is sort of the trends that we can see over time. So the orange and gray lines here are what we're calling the West Coast, or many people would call it the California variant. And you can see that really predominated up until February or so. That was really the predominant. Those B1429 and B1427 were our dominant strains in California, and then those have gradually been decreasing and are being replaced actually by B117, which is the UK variant. So about half of our strains that we're isolating as of April are actually B117. But again, thankfully, I think we have been using all of our other mitigation efforts in California, all of our mask wearing and distancing, along with getting people vaccinated, have really I think help prevent surges we've seen in other states and countries where the UK variant really took off because people had let their guard down. And then the other trend that we're seeing is P1, which is one of the Brazilian variants, is also on the increase, still less than 10% of what we're sequencing, but something we are keeping an eye on as well. And then also not on this graph because it's only a few, less than 100 isolates, but we have seen the Indian variant, the B1617 here in California as well. And that just got reclassified by the CDC as a variant of concern rather than just a variant. I think it actually didn't even have a variant of interest classification until recently, but something we will also obviously keep our eyes on. Next slide. And then how's our progress on vaccination? So really pleased to tell you that we have over almost 62% of our population 16 and older has received at least one dose, and we're getting close to 20 million people with that. And then fully vaccinated, we have 14.3 million people, and 45% of people 16 years of age and older are fully vaccinated here in the state. So really getting close to half. Next slide. And then we'll talk really soon about how we're going to be able to open up that denominator very soon. But before I move to that, I also just wanted to, again, with an eye to equity, show you. So again, the blue line is our least healthy quartile, least healthy community conditions quartile, or HPI Q1, and then the green line is HPI Q4. So you've seen we've had some started out with a pretty wide disparity, especially, some of the first waves of vaccine, as you all remember, were healthcare workers, and then we did vaccinate the elderly initially. So we had a wider gap, and we were able to close that, especially we started to reallocate more of our vaccines into our least healthy community conditions quartiles. So that was in March. We started to narrow that gap, and then I think in April is when eligibility opened up to all comers again. And I think, again, those who were motivated and resourced were really the proactive ones going to the mass vaccination clinic. So we unfortunately saw that gap widen again, but we have seen, as you can see here, made a lot of progress again just in the last couple of weeks with a lot of efforts we're doing. We've really focused both at the state and local level on where we see the communities statewide that have the least healthy community conditions and really working with our local health department partners on the ground on what are some best practices, what's the ground game there, what are other incentives, how can we bring more mobile sites to people rather than expecting people to come to these mass vaccine sites. So although we have seen, as you've all heard, less demand, especially at these mass sites, we are making some efforts and I think progress on the ground game and the mobile outreach and making some progress with our equity as well. So stay tuned on that. Next slide. And then, the other common question that's coming up that I wanted to share some of our relatively recent data, and we'll work on trying to do periodic public updates of this on our website in the near future as well. The CDC has also posted data on, what are, sometimes people are calling these breakthrough vaccination cases. I think we're trying to really shift to calling them cases or fully vaccinated persons who test positive, because sometimes it's actually an incidental finding as well. They may not even have any symptoms. But over the course of January 1st to April 28th, we looked at our data, our case registry data, so all the reported cases, and our California immunization registry, including the San Diego and Central Valley immunization registries, and did a cross-matching to see. And we identified over 12.1 million fully vaccinated individuals in the immunization registry. And in the cross-match, only 3,000 or so post-vaccination cases. So when you look at the percentage of that, it is way less than 1%. So, really, really low numbers of people who've been fully vaccinated who have tested positive in California. Of those, only 4% of the 3,084. So of that 0.0003%, only 4% of those were hospitalized cases, and then only a handful, or 1% of those actually were reported as death. And we haven't done the deeper dive to see how many of those might have been, again, incidental findings upon hospitalization or death, or were they actually hospitalized for COVID-19 disease. So I think that's a whole nother layer. But again, really encouraging data as far as the effectiveness of these vaccines. Next slide. And then wanted to just provide an update on Johnson & Johnson vaccine. So as you all know, in mid-April, there was a pause. There was a description of thrombosis with thrombocytopenia syndrome, and there are 4 criteria that the Hematology Association has put out there as far as the diagnosis of this clots with thrombocytopenia, which is actually a pretty rare disease with that thrombocytopenia. So the sort of again, 4 criteria for this diagnosis post-vaccine, and right now it's really just with the adenovirus vector platform vaccine, so Johnson & Johnson or AstraZeneca, within the last basically 30 days previously, and then a large, as most of the initial cases, as you all know, were cerebral venous sinus thrombosis, or there were also splanchnic or other abdominal thrombosis, but venous arterial thrombosis, and then low platelets, again, is the real hallmark of this compared to other kinds of venous clots. And then the other real definitive thing to test for is the heparin-induced, similar to the HIT or antiplatelet factor antibody positive testing. So those are the diagnostic criteria for that syndrome. And then this link on here, you can also see the full recommendations from the American Society of Hematology about both the workup and, really importantly, also making sure if you're suspecting this to not treat with heparin, because that can really make it worse, and not to give platelets. So that was another really important part of the pause, really improving clinician outreach as well as individuals in the public as well, but making sure individuals knew how to work this up, diagnose it, and also do the appropriate treatment during the workup. And as of April 23rd, the pause was lifted, and the ACIP panel also kind of reviewed the benefits versus risks of this, this phenomenon with vaccine. Next slide. And just some data from that ACIP meeting on April, late April. So there were around almost 8 million vaccine doses administered. And amongst those, after that pause and during that time, the case reports, they accumulated 15 total of these TTS cases, in addition to, originally there were 6 identified that led to the pause, and then another 9 were identified as of April 21st. So this sort of shows you, breaking it down by females versus males, what the rates were basically. So for females 18 to 49 years of age, that is the risk group, and I think a good overlap to talk about here with thinking about women of childbearing age, but 7 per million was the reporting rate, so that was the higher rate as far as the what was seen in those 15 cases and the 8 million doses. For men, there really were no cases identified and confirmed as of that April 21st date. And then in the 50-year-old and over, it was 0.9 per million overall as far as the reporting rate. Next slide. And then what the ACIP did was look at benefits and harms of resuming vaccination for ages, and they looked at, the pros and cons of having it resumed for all ages versus just 50 years of age and older, and how you could compare the risk of this TTS syndrome amongst the number of vaccinations versus deaths and ICU admissions averted. So again, looking at 18 and over, for every sort of 2 potential cases in the 50 to 64 years of age, or 24 cases of TTS in the 18 to 49 years of age if resumed, amongst 10 million or almost 10 million vaccinations. And the presumption there was that the background rate of transmission was moderate, and if vaccine resumed at 50% of the rate before the pause, kind of also trying to model and assume for some potential loss of vaccine confidence, this would still prevent 1,435 deaths and over 2,200 ICU admissions. So again, this is where really looking at it at a population level, the benefits really outweighed any risks to resume vaccine. And then they also looked at this for ages 50 and over, where you might have less cases of the TTS, but you also averted fewer deaths and ICU admissions. Next slide. So before I talk about this, sorry, so just to close that out. So again, on April 23rd, that pause was resumed, and I have not heard about other reported cases in California or otherwise. And again, I think it's really important to counsel, especially women between that 18 to 49 years of age, about and making sure that people know about their choices, but also that this is a really valuable vaccine that we have in our toolkit to, again, help get us beyond this pandemic. So then shifting gears, I'm sure everyone knows, and especially the pediatric provider population, and certainly the parent population, has really been eagerly waiting. And many of us were happy to hear that yesterday the FDA approved the amendment to the emergency use authorization of the Pfizer vaccine to expand use in adolescents 12 to 15 years of age. There were data from their phase 3 trials that showed both good efficacy, good vaccine tolerance, excellent safety. I believe it was over 2,200 or so that were enrolled in the trials, and I think 0 of the vaccinated teens actually were tested positive for COVID-19. So next slide. So we are doing a lot of planning at the state health department level. We've been partnering, really appreciate the partnership with CMA, also the AAP and the California Association of Family Practitioners as well, and our third-party administrator, Blue Shield. We've been working a lot behind the scenes to expand availability to more youth-serving clinics, working a lot on school-based health clinics, and/or a lot of efforts that were already underway to really bring, again, vaccine into communities with school-based vaccine clinics. And of course, pharmacies are also going to be providing vaccines to this expanded age group as well. Our communications team is working on doing surveys of parents. I just saw hot off the presses, we're going to be looking at parent surveys about interest in vaccination of this age, and also a lot of communications and outreach to empower youth to advocate themselves and to sort of get their confidence in vaccination. So as I was already discussing, there's already been a big shift from mass vaccination clinics to community-based vaccines, and also to smaller providers where a lot of parents and patients really want to be having those conversations with their primary care providers and their pediatric or family practitioner providers as well. So we're really hoping that will help address vaccine access and confidence. Another partnership with the CMA today is a webinar that will happen later on this afternoon or early evening, where our teams are collaborating to kind of provide an overview of how these smaller providers can now get enrolled and get onboarded to MyCalVax and be eligible to receive vaccine. We're also working on, there's a lot of logistical issues related to Pfizer vaccine with the ultra low temperature and the large allocations that come, and how can we work both advocacy on the federal level and what can we do in the state to help break down that packaging and really make sure, again, we can get more vaccine into different providers and really spread vaccine out into the community so we can get more people vaccinated, where they can, again, have conversations with their trusted providers. Next slide. And then a common question that's coming up, and it's more just a stay tuned. I think we all have seen some of the data that, you know, Pfizer and Moderna certainly have at least 6 months of immunity as far as antibody persistence. And, you know, these vaccines have only been around for a little bit more than that, for about 7 or so months. So I think there's a lot of work going on with the manufacturers and other studies to look at whether or not boosters are going to be recommended. And of course, again, with a close eye to variants and if they'll be needed for variants and or waning immunity. But there are no current recommendations yet on whether boosters will be recommended or that timing. So it's another stay tuned topic. Next slide. And finally, just some other resources for providers. You know, a lot of different websites that we have as far as EasyIZ is our general immunization resources for providers and enrollment, and then CalVax, and then our other immunization pages. We have a call center for providers as well. It's dedicated just for providers to any technical assistance needed for enrollment or other vaccine questions or issues. And then, of course, other CDC resources as well. Next slide. And I think with that, I can pause and take questions.
Thanks as always, Erica. As always, we have so many amazing questions from our audience, but we're not going to be able to get to many of them today. One thing that I did want to ask you about is as vaccine protection increases in our state and disease prevalence decreases, are you thinking about changing quarantine recommendations around people who are traveling, for example? I know that's coming up for a lot of families as they think about traveling for the first time many times over the summer as kids get out of school. And it's more complicated just because kids are likely not to be vaccinated.
Yeah, sure. No, it's a great question. And I think, you know, I think our big emphasis, although you brought up the challenging part of it, but is that if people are fully vaccinated, we and the CDC say, yeah, you're good to go. You can travel. I think we do have a lot of concerns still about unvaccinated people traveling. I think especially looking at what's happening around the world, right? I think a percentage point I saw, it was already a few weeks ago, but I don't think it's changed significantly, is that 80% of the world is in surge right now. If you look at the CDC list of countries right now, or the global map, I mean, most of the world is in surge. I showed you that national map. There's a lot of states that are still in surge too. So we do have a lot of concerns about people traveling in either direction, actually, who aren't vaccinated. So we're not changing any recommendations right now for testing pre-travel and testing post-travel and quarantine post-travel for unvaccinated persons. So, and I think, you know, the other thing I didn't mention, but I am hearing, and many of you have seen this probably in the news as well, and I think there's really encouraging news about how soon some of the manufacturers are going to be applying for vaccine approval, and that they'll have data by September, I think, for the much younger age groups as well. So I think at this point, for me, as a parent, I feel like, you know, until my kids are vaccinated as well, I'd really rather wait. And I've heard some, you know, an unfortunate story in the media recently about a kid that traveled to Hawaii and actually died there. I think it was a kid with underlying medical conditions, but still, I think it is still risky. And I think with the variants and the surges happening elsewhere, I think I'd really rely on vaccination first.
Yeah. Well, I will say my own two kids my girls are 8 and 10, and the 8-year-old is one of those kids who like 10 clinic staff have to hold down every time she needs a shot. They have an opportunity potentially to be in a vaccine trial. And the little one, I said, you'll have to get extra shots. And she thought for a minute and she said, Mom, I'm going to do it, because they are just so eager. So Erica, I love the idea of actually having the teens and then eventually the younger kids advocate for themselves in some way about this. I do just want to share that I actually have the information on the webinar that you have. I'd like to share with everybody. It is tonight, and it's 5 to 6 p.m. And you can find that on some website, but there's on CMA website, you should be able to find the link to register. So maybe one of our, the people who's organizing this can put that into the chat. I'm not quite sure if that'll work today, but that's a great opportunity from the beginning. Many of the listeners have been really interested in having small and solo practices be able to get some vaccine to administer. So that's great news. The one final question I just want to ask before we close out is about, you talked about the cases in fully vaccinated people. Is there any increasing data on whether fully vaccinated people are infecting others? I recognize that's hard to do. Is there any data in that area?
Yeah, I think there's more and more emerging data actually that kind of in combination answer a couple of those questions is that while there are people who are fully vaccinated that test positive or might have asymptomatic or mild infection, you know, when people have been looking at things like their and even sort of just hearing about some of the outbreaks where people are just getting tested, like everyone in an environment like a nursing home or other things, people who are asymptomatic and testing, and also looking at their cycle times on the PCR, that they're really low levels of detection. So I do think there's more and more evidence really suggesting that people who are fully vaccinated are not transmitting to other people. But as we all know, we're still kind of waiting for more data, but I do feel like the case is getting better and better, that that's really unlikely. So I think it's another encouraging thing. And certainly that's been true for other vaccine preventable diseases as well.
Great. Well, unfortunately, we are out of time today. I really want to send huge thanks to you, Erica, and to Drs. Rao and Nielsen for today's content. Thank you to everyone who's listening in and taking the time to learn from our webinar. Remember to share it with colleagues. It'll be up on YouTube by tonight, but you can find that information on covidroundca.com. Our next session will be on Tuesday, June 8th, and it's looking to be a very exciting one. And just always remember that CMA does provide lots of other webinars and resources on the CMA Telehealth Tipping Point Project, and that's cmadocs.org/telehealth webinars. Don't forget, if you want CMA to fill out your survey today around 4 p.m., it should come into your in-basket. And everyone have a wonderful afternoon.
Great, thank you very much.